somebody reached out to me on Facebook, another professional, and we were talking about Hallux rigidus, Hallux limitus, and he had some questions, so I figured it'd be a good opportunity to answer them online. So the first kind of question comment was, what could a physical therapist do to get around the solid physical impediments, meaning like bony formations, exotosis is the word for it, blocking dorsiflexion or the lifting up of the first metatarsal phalangeal joint, which is the big toe joint. So the way that, I don't know how other physical therapists would do it, but the way that I do it is I would first remove the pressure and irritation both externally, right? Because it could be the shoe that's irritating that area and kind of making it worse because skin and bone respond to pressure. When we're talking about the bony impediments, right? I don't know for sure that is the bony impediments that are causing that block of dorsiflexion. It very well could be, but I don't know that for sure because there are other things that can limit dorsiflexion of the first MTP joint, including instability. There's a saying we need to have stability in order to have mobility. Inflammation could be another thing, as well as a lack of movement through the kinetic chain, because movement does not occur at the joint. And I learned this years ago with a profound case where I was treating ankle dorsiflexion or lifting up on a patient who had cerebral palsy. And I thought for sure there was no way that I was going to be able to do this. It was neurological tone, right? That's what my brain said. That's what my training said. But sure enough, when I worked through the kinetic chain beginning at the big toe, and I only worked the big toe because I didn't need to work any further, she achieved a 5-degree increase in dorsiflexion range of motion, and I almost fell over because I did not work her ankle at all. So the integrity or movement of the connective tissues around that area can impact the first metatarsal phalangeal joint range of motion. So the lack of range of motion may not be 100% due to a bony formation or an exotosis. There's also some research, and I don't personally use it, but there's some research that supports the use of iontophoresis to decrease bony buildup, exotosis. And I found a website, and I also found a research article using acetic acid with iontophoresis. Iontophoresis is using electricity to drive medication into an area. And there has been some research to support that. So that would be another thing or possibility that I could do without necessarily having the person go under surgery. So then the next comment was that forcing motion accelerates the destruction of the joint. Absolutely. Absolutely. I never, ever, 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 ever mobilize the first MPT joint in Hallux rigidus, Hallux limitus. But you'll be damn sure that I release the distal hallux. I release the joint in the big toe between the proximal and distal hallux. I release the proximal first metatarsal at the arch level and even halfway down. I release all the other metatarsals. I release all the tarsals. I release, I release all the way up to where the connective tissue that crosses the big toe joint originates. And that goes all the way up into the calf. And some people have found fascial connections. I saw this on Facebook. I don't know about validity. Fascial connections between the tongue and a muscle that goes all the way to the tip of the big toe called the flexor hallucis longus. So there could be a lot of influences that limit dorsiflexion. So yes, I never, ever, ever force motion at the first metatarsal phalangeal joint. In fact, I use specialized tape that has the force of the equivalent of 33 pounds of force to offset the pressure on that joint and also hold it in a better alignment. I actually create a lever with the alignment of the toes using this tape that increases the lever and allows the distribution of forces off of the first MTP joint all the way to the end of the big toe. And that is something that I find clinically with people who are predisposed to Hallux rigidus, Hallux limitus, is that the tip of their big toe is pointed up. And I would almost argue that this might be hereditary. And the reason I say that is because I noticed it in my daughter at about age 5. So there's another thing that needs to happen. So what else would I do? I want to decrease the inflammation because the inflammation will shut down the core muscles. The core muscles are our stabilizers. And remember, we need to have stability in order to have mobility. I do that, I mentioned, through taping, not just for alignment, but I'll also facilitate those core muscles to start working by putting tape over them. Okay, the core muscles of the big toe, specifically the flexor hallucis brevis, the adductor hallucis oblique, and the adductor hallucis transversus, as well as the abductor hallucis, just for kicks, because I really want to stabilize that joint. So I get it from the top, I get it from the side, I get it from underneath. And then I also reinforce it with stabilizing exercises that are specific to the big toe. Stabilizing exercises do not move the joint. They are isometric, meaning that they do not move. The idea of stabilization, again, is to get, once you address the inflammation, is to get those muscles to fire again so that they can protect that joint, and then they can allow the moving muscles to move. And doing so, I use a technique that I learned in my advanced training of physical therapy called proprioceptive neuromuscular facilitation, where I do a technique which is called rhythmic stabilization, meaning that I challenge the joint by applying forces that do not allow the joint to move but activate the muscles. So it's almost like if I was trying to push my arm down, I could overpower my arm, right? But I'm not doing that. I'm going to apply a force where I can meet that force with my arm that is resisting it. But notice I'm not moving. So I'm not putting any pressure on the joint or any irritation to the joint, which again, I believe that Hallux Limitus is really caused by excessive mobility at the first MTP joint, which causes bony formation because of irritation and pressure, which then becomes further limited, further inflamed, and eventually fused. So we don't want to have to get to the fusion point, any of us. And so I was having a conversation with someone much like this, a professional who's a podorthist, and he deals with treatments of this kind with shoe modifications and orthotics, which are awesome, absolutely. But what about the time that we're not in those shoes, or that we might have an occasion that we want to dress up, or, you know, we're going to go out hiking and do a lot of exertion because we really want to hike with our friends, but we're not, you know, we're not able to do it. Or we're scared to do it, or we're just going to have to, you know, chug a bunch of Advil to get through it, right? You shouldn't have to do that. There are ways around it to make it easier on yourself. And certainly, like, at the bare minimum, taping is a huge intervention that you can take when you are not in the footwear. Lastly, this person said, what I don't like to see are patients who have been led astray by health practitioners who cannot offer the full range of treatment options. So they suggest other options that waste time and money. And I couldn't agree more. I don't personally take on any clients that I don't feel that I can help. And the program that I have online, that's a DIY program for Hallux rigidus, Hallux limitus, as well as bunions and hammer toes and tailor bunions, has a money-back guarantee after 14 days. They are extensive programs, and they really do offer a full range of treatment options, as well as informing the public about the importance of footwear, especially with toe dysfunctions, or as I should say, forefoot dysfunctions. All right. Well, I hope that answered your question. If you have more questions, or if you'd like to reach out about the research or article on ontophoresis, please do so. You can PM me on Facebook, or you can email me, support@dlwalkerconsultant.com. I hope that answered everything. And really, thank you for having the opportunity to explain myself, because I acknowledge that, a traditional physical therapist is not trained in this area per se. However, a seasoned, experienced, and passionate PT has the knowledge base to kind of really learn any part of the human body. And I know that I've had fantastic physical therapists change my life for the better, doing things that they didn't learn in PT school. So I really do understand your opinion there for sure. And I don't expect every physical therapist to do what I do, but I really would like the opportunity to teach them someday, or even other professionals who are passionate about feet like I am. All right. Thanks again.